Wow. Good afternoon or evening, everyone. On behalf of more than 1,200 ARCS members throughout the United States, welcome to the fourth session of ARCS Forward, a National Scholars Speaker Series. Really good to see many faces, some I recognize, many I don't, but thank you each and everyone for being here. Today, our topic is public health, and I'm really excited about this because before the pandemic, very few of us knew anything about public health. And we've learned a lot. And today we're going to learn even more from two fabulous scholars, Elizabeth Sajewski and Will Mundo. I'm Jo Whitehouse. I'm a retired physician and drug developer and a recent past president of the Northern California chapter of ARCS. You know, being a member of ARCS for me allows me to interact with brilliant young scientists. I really enjoy that. And it also allows me to meet women and sometimes men who are also curious about what's going on in science, and ARCS is such a great way to explore it. ARCS Forward is actually a fairly new initiative on the behalf of the foundation. And the committee has worked hard on this and established it as a speaker series featuring scholars or sometimes alums in topics that are both relevant and scientifically interesting to scientists and non-scientists. Using our fantastic network of current scholars and alums, we're able to bring together 2 or 3 that have similar research interests and have them share with us their ideas and the reason that they're working on these topics. The past session on prostate cancer was excellent and well attended, and we've also had one on the environment and climate. So let me just briefly tell you a little bit about ARCS. ARCS, this is difficult because it took me 2 years to learn this. ARCS stands for Achievement Rewards for College Scientists. It's much better to use ARCS. It's a national nonprofit founded in 1958 by women and still run and managed on a volunteer basis by women. We currently have 15 chapters across the US, and our mission is to advance science in the United States by providing unrestricted financial awards to academically outstanding US citizens in STEM disciplines and medical research. So since 1958, 63 years later, we're still all women, and we have provided awards to more than 10,000 scholars, or fellows, as some people call them, totaling more than $122 million. We're very proud of that. Again, thank you all for showing up today, and please feel free to post your questions in the chat function. We will have time for Q&A and at the end. And now I want to get us started. So first we're going to hear from Elizabeth, and then we're going to hear from Will. Both of them have some overlapping and different areas of research. And we thank each of you for giving time and talent for being here today. So Elizabeth, over to you.
Great, thanks so much, Jo. So I'm going to start by sharing the screen and then dive in. Okay. As Jo kindly introduced me, I'm Elizabeth Sajewski. I'm a 5th year public health student, environmental health science PhD candidate at Emory University in the Ramon School of Public Health. I'm also an ARCS Atlanta Scholar alum and a past recipient of the HERS Global Impact Award. So my background is in environmental engineering and environmental consulting, done a lot of work in human health risk assessment, but ever since starting my PhD, I've really been able to dive into my passion, which is infectious disease transmission. So today I'll be talking to you about environmental science, about the impact of public health globally in some of my favorite kind of areas, which are water and vaccines, and then how I use models as a technique in my research. So diving in, one of the most common questions I get is, what is environmental health science? So there's a lot of words in there. So people sometimes think I study environmental science, sometimes think it's some form of something else, but essentially it's exactly what it sounds like. So through environmental health science, we're a field of public health that considers the way your environment, from the water you drink, the air you breathe, chemicals that you're exposed to, either through pesticides in food or in your home, or in your environment around you, how stressors like climate change and heat, or natural disasters can impact health. And this field really epitomizes what I want to get across as one of the key tenets of public health, and kind of the background behind public health is that it's about thinking on these broader scales and thinking not just of you as an individual and your health, but about how your health can be influenced by all of these different factors outside of you individually, by your environment, and by your communities. So that gets us to our next slide, which is, what is public health, right? So I've mentioned environmental health science as a piece of public health. Joe talked about how we're a lot more aware of public health now, but I just wanted to kind of go back to, at the root, what is public health? So this is a definition from C.A. Winslow, who is kind of a founding father of public health and the founder of Yale School of Public Health. And he defined public health as the science and art of preventing disease, prolonging life, and promoting health through the organized efforts and informed choices of society, organizations, public and private communities, and individuals. And I really want to focus on here about how, again, public health is not just about those talks that are happening between you and your doctor. It's not just about how you're taking care of yourself, but it's about how, as a society, we are taking care of each other, about how we are investing in infrastructure and in health, from the government, from community levels, and as individuals, all making choices to benefit our communities and to benefit the health of each other and ourselves. And this is kind of a theme I'll come back to throughout my presentation, this idea that public health is about much more, is about thinking across scales and thinking about how health is impacted at these higher levels. Okay, so as a quick overview, I'm first going to dive into water and health, kind of the bread and butter of public health and where I started in public health, and then talk about vaccination, my current passion and a hot topic, I think, today, but over really the past century. Then I'll dive into my research methods and using models, to how models are used in public health, and finally wrap up with some examples from my research. All right, so diving into water and health. So one of my favorite public health stories, and really the reason I started researching public health, was because of the story of John Snow and the Broad Street pump. So London in the 1800s, going way back to kind of the beginning of this idea of public health, was not a really great place in terms of health. Prior to the introduction of running water and a modern sewer system, it was pretty grim. There was no form of water treatment, and most people in town relied on communal wells or a communal pump for their drinking water and all their water needs. And untreated sewage poured directly into the Thames River, or was kept in open pits. Knowing what we know now about the importance of clean water and sanitation, it seems like that was a recipe for disaster. And indeed, between 1831 and 1854, tens of thousands of people in London died of cholera. And that's kind of what's illustrated here through this cartoon, where the pumps were kind of just pouring out death. However, rather than look to the water, most people at this time believed in this theory of miasma, so that bad smells led to the cause of disease. One of the worst cholera epidemics occurred in the Soho district of London in 1854. So that's this area. I think I have one more. There we go. So that's this area of London. Whoops. And 600 people died within just a few days. And so John Snow, who's represented as kind of one of the fathers of public health, came onto the scene, and he is kind of one of the reasons I got into public health, was hearing this story. So by mapping out the cases of cholera, as we see here around the district, he found that most of the cases were centered around this pump. So looking not just at individual cases, but about the map of the cases, putting them all together on this scale of the city, he was able to identify that this was the cause of the outbreak and remove the pump handle, and the outbreak subsided slowly soon after that. So essentially thinking about looking across scales to think about health on a broader scale, to think about where these cases were occurring on a broader scale. This theory of water treatment and thinking about water as one of the main ways disease can spread kind of developed from that point. So again, looking into this political cartoon, we see in the 1890s, typhoid was a main cause of disease. And this was one of my first research topics, was researching typhoid around the turn of the century and thinking about how the introduction of municipal water systems, so this municipal water treatment plant beating down typhoid, and also then the introduction of chlorination, really led to a decrease in typhoid. This particularly was in the US, but we see this really throughout the Western world. When water treatment and chlorination was introduced, we saw huge declines in death. So, which is shown in this figure here as well. The introduction of chlorination led to huge declines in typhoid fever. And this, to kind of sum this up, this really shows how community investment in infrastructure upstream, so investing in these municipal water systems, leads to clean water and a healthy population downstream. So we see how public health is acting at a different level. It's acting upstream of the impacts that we want to see. So, you know, in John Snow's London, they were seeing a lot of people dying, but John Snow looked upstream to see, oh, what's actually causing these deaths? It's the water at the pump. Let's look at a larger scale. Let's see how we can interrupt this chain of transmission. The next topic I wanted to talk about is vaccination. So we've heard a lot about vaccination recently, but vaccines, after I think about the advent of water treatment, thinking about vaccines is one of the greatest ways that public health has impacted the global burden of disease was through the introduction of vaccination. So we see from 1980 to 2019, there's been a huge increase in that global vaccine coverage across a whole range of vaccines. So we see, for example, polio and tuberculosis, those had spikes early on, but some vaccines took a longer time to come up. So measles, for example, was a kind of a slower trend up, or rotavirus vaccine has just been introduced really in the past 20 years. But with the introduction of these vaccines, we've seen huge declines in global mortality, particularly global child mortality. So this again is showing from 1990 to 2017, how global numbers of child deaths have declined from about 12 million to about 6 million. And in particular, these colored bars representing, colored part of the band representing vaccine preventable causes of disease. We see a really big shrink in these infectious diseases that are causing deaths. So here we're seeing vaccination, huge impact on deaths and on public health globally. And just to kind of extract one point, there's been vaccines aren't an old story. There's been a 73% decline in measles deaths just over the past 20 years due to an increase in vaccine coverage to about 86% globally. So vaccines are an interesting case because we know that vaccines, when you're vaccinated, that can protect you. But the big story that we've been hearing a lot about is how vaccines can contribute to herd immunity. So again, you might be getting vaccinated to protect yourself, or be thinking about when we're vaccinating children, we're trying to protect individual children. But vaccines also contribute to this idea of herd immunity, where the more people who are vaccinated, it leads to outsized effects beyond just protecting those who are vaccinated. So in this infographic, you can kind of see where if you just have a few people vaccinated, and one person is infected, the disease can spread to a lot of other people. And so though the people who are vaccinated are protected, you still have high transmission of disease. But if you have lots of people who are vaccinated, that protects the people who are unvaccinated. So the individuals who are infected can't have contact with as many people who are unvaccinated. So the vaccinated people kind of act as barriers of protection to people who are unvaccinated. and are also protecting themselves. So this idea of herd immunity is one of the main reasons why vaccines are so important and why vaccines are such a critical part of public health, where the choices, where as individuals, people are choosing to get vaccinated. And then that can scale up to this herd immunity impact and a decline in the population burden of disease. Now, it's also important to mention that it's not just about individuals choosing to get vaccinated. It's also about investing in healthcare infrastructure and having the infrastructure that supports both individuals having access to vaccine and then also scaling up vaccines. And we see that both in the United States, that's been a big thing with COVID vaccination recently, but we also see that globally, where in a lot of cases that scaling up of vaccines can be challenging, and there's a lot of global support for that in different settings. So diving next into research, I wanted to talk about the way I research public health and the way these different thoughts about scaling across different layers of impact of public health interventions like vaccines are captured in my research. So a lot of times when people think about research, they think about field and lab research. And thanks to the support of ARCS, I've been able to dive into this type of research. And I, earlier in my grad school experience, I performed a lot of research in Mozambique on water quality. So going into the field to collect water samples and then testing them in the lab for contamination as part of a project looking at municipal water systems and the impact of expanded pipe water access in urban settings within Mozambique. However, the majority of my research looks more like this. Not always with a beautiful view of the Atlanta skyline, but often with a view of my computer screen and these types of mathematical models. So most of my research at this point is computer-based, where I am using models and equations to tell stories. And I think we've heard a lot about models over the past couple years. So I wanted to demystify that a little bit and dive into what a mathematical model actually is and how these are such great tools for public health. So models tell a story, and that's actually how I see myself as a public health researcher, particularly as a model. I see myself as a lot as a storyteller. So I'm telling a story about how infections act on an individual level. So once you get infected, how long are you going to stay infected? How much virus are you going to be shedding? How your immune system interacts with that infection. Then I think about how people interact with each other. So what are your contact rates? How often are you going to be contacting other people? How often are little kids contacting each other or contacting their grandparents or contacting kids at school or their teachers? All of these different ways that people interact. And then thinking about putting that all together to think about how disease is transmitted in a population. So how individuals move from being susceptible to infection to infected with disease and then potentially recovered. And models allow us to tell this story, to capture all of these different aspects that are important to tell about how diseases move through populations. Models also can bring together a lot of data. So I think we're infiltrated with all these different kinds of sources of data a lot. We think about big data and who's taking all our data, but in public health, it's really important to think about how we can best utilize all the data we have, because we're very lucky to collect data from people. And it's important that we utilize that data to its greatest extent so that we're making use of the contributions that they're making to public health. So that can bring together all sorts of different data that a lot of it is tied more to the types of research that you think about when you think of scientists doing research. So that could be trials that people are putting together. It could be different studies in the environment, looking at the individual diseases, looking at the burden of disease in populations, thinking about how people are exposed to pathogens, environmental sampling, sampling of the population, surveillance data. So all of this can come together into a modeling framework, which can then inform interventions. And lastly, models are important because they let us explore. So they let us dive into how different interventions or policy changes can impact the burden of disease, how different assumptions we make about how diseases spread or how people interact can change what the projected disease burden might be, and how gaps in data might influence how we're able to project disease. So we've seen, again, this has been a really common thread where early in the pandemic, we didn't know very much about COVID-19, how it spread, but we were able to use models to make predictions and to test how much different assumptions might influence how much the pandemic will spread. So now I just wanted to quickly go into one example of how storytelling and using models as stories can help us to influence policy and to influence the direction of research in public health. And for me, it's been modeling pediatric norovirus vaccine. So you all might be familiar with norovirus in the news. It's often associated as a cruise ship virus. It's linked to food poisoning often. It's hard to clean up. There was an outbreak at the Olympics, and essentially you don't want norovirus. It is not a pretty disease. But it's one of my favorites, and it's one I spend a lot of time thinking about. The norovirus burden is also one of the leading causes of acute gastroenteritis in the United States, and there's 20 million cases annually. So it's predicted that people are going to get norovirus about 5 times in their life. The highest incidence is in young kids. So this is a plot that shows how the incidence of norovirus per 100,000 people, and we see in kids under 2, those bars are the highest. So we see the most norovirus. But we also find that in older adults, we have the worst outcomes in terms of deaths from norovirus. But luckily, vaccines are currently under development. There's no vaccines currently on the market, but they're under development. So that leads us to the question of how can we best utilize these vaccines to alleviate that burden? We have a very crowded pediatric vaccine schedule. We're interested in vaccinating little kids to help alleviate that burden, but you can see already there's a lot of vaccines for little kids. So where do we want to slot in norovirus vaccines to have the biggest impact? And how can we line it up with all these different kinds of schedules with the vaccines that already exist? So to answer this question, let's build a model. So when I developed my norovirus vaccine model, I was able to tell the story of norovirus infection. So you're infected for 2 days, for example, and think really specifically about how little kids are infected with norovirus. I was able to tie it to data. So we have really great surveillance data from Germany, as it turns out, of norovirus cases. So I was able to tie the data to German data and then translate that to the United States to make sure that the story I'm telling actually matches up with the real world. And I also added in vaccination to add in that element of exploration to see how that story will change when we add in vaccination. And what we find is that if we add in pediatric norovirus vaccination with the vaccines that have similar efficacy to the ones we see under development, with early vaccination, so vaccination on kind of those earlier schedules, we could avert up to almost 45% of norovirus cases in young children, which is great. But one of the really cool things that models are able to tell us is that we'd also avert over 10% of cases in older populations. So these are people who aren't vaccinated at all, but they're protected from norovirus because of that herd immunity effect, because they're not getting it from their child who's not getting it because they're vaccinated. So this was a really cool aspect of looking at modeling. So I might wrap this up a little bit quickly because I don't want to run out of time, but I just want to speak really briefly to this idea that modeling can also be used to extend to thinking about a lot of different sides of it. So my current project, I'm looking at modeling exposure routes. So thinking about how at an individual level, how the amount you individually cough, or if you're touching surfaces and then touching your face, or if you are wearing a mask or not wearing a mask, how that impacts individual risk. And then how at a population level, if we add in testing and vaccination, how that can impact the transmission of COVID-19 among food workers. So looking in this very specific population, telling a story about how at the individual level, they might be at risk for COVID-19, and then how all those risks come together with different interventions to impact the spread in this population. So I'm going to skip over this. But essentially what I wanted to get to is that this kind of model-based research in public health can help us to inform policy. So when we're thinking about, if we're going to have testing or vaccination rolling out in different populations, how important is it to hit certain vaccine targets? And if we don't hit those targets, what do we have to do? It can help us design better interventions. So know if we're going to vaccinate little kids, what's the best time to vaccinate those kids? And it can help us direct research. So where are the gaps in data that we really need to fill in to better do our research? And all of that adds up to lives saved, improvements in health and well-being and productivity. So really these outcomes we want to see from public health, improving health in our communities, from thinking all the way back to these interventions and the way public health acts across scales and disease acts across scales to transmit and to be stopped in being transmitted. So with that, I'll wrap up. I wanted to say thank you so much for listening. I also want to say a huge thank you to the ARCS Foundation. I mentioned earlier that it was through ARCS support, both in terms of funding, but also just connecting with members and the support of the organization that allowed me to dive into both my research in terms of doing international research in Mozambique, and also supported me in learning new methods for modeling and going to modeling workshops. I also wanted to particularly thank my funders, the Hertz Stuffing for the Hertz Global Impact Award. And then I wanted to just thank the Lotman Lab, which is my lab at Emory, and my environmental health sciences program. So that is all I have for now. I think we're going to go over to William next, but I wanted to thank you for your time.
Actually, I'm going to jump in and say thank you, Elizabeth. I have never heard a more passionate discussion of vaccines, water, clean water, and mathematical modeling. So thank you. Will, take it away.
Great, thanks. Yeah, I have to agree with Joe. That was very impressive and very passionate. Thanks for that, Elizabeth. And so here, let me pull up my presentation. Okay. Great. So let's see here. Thanks again, everybody, for being here. And inviting me to come speak to you all. My name is William Mundo. I go by Will. I use he, him pronouns, and I'm currently a fourth-year medical student at the University of Colorado School of Medicine. I'll be graduating in the spring and pursuing a specialty in emergency medicine. I'm also a graduate of the Colorado School of Public Health, where I got my master's in public health. And I'm here this evening to talk to you about my research to highlight the intersections between public health and medicine in my career. And so just for brief background for what this presentation is going to tell, it's pretty much divided into three areas. So the first is an introduction, kind of covering some of the foundations that Elizabeth covered, going a little bit deeper into those concepts and comparing it to medicine and why it's important to medicine. And then I'll be using a clinical case to highlight some of the topics I discussed in the first section. And then the last part is going to be talking about next steps for my research, and also a framework, the framework that I've been using to address health inequities. And so just to start us off, I'm not going to belabor this point because I think Elizabeth gave a pretty awesome introduction to this. And so public health is really, like, again, the art and science of preventing disease, prolonging life through organized efforts of society. And so really when I think about public health, I think about the three powerful P's, and that stands for prevention, promotion, and protection of health. And so when I think about public health, I think about the patients really being the community. And how that's different than medicine really is that medicine is still an art and science, but it's more focused at treating diseases. It's focused on finding cures and using the scientific method to figure out what's going on with patients. In medicine, we use technologies and a bunch of drugs to treat illness. And here the patient is the individual. Now, I really like this upstream versus downstream approach that Elizabeth discussed. And just to even simplify it a little bit more, a way that I like to think about it is thinking about a river. And so downstream here, you have people in the river And then you have these people who are pulling them out. And essentially these people who are pulling them out of the river essentially function as like doctors in our society, right? They're going in, they're saving the people who are drowning and treating them. Now, if we look a little bit upstream, here we see people falling in. And so now the public health practitioner, the question they're asking is like, why are people falling in the river in the first place? You know, is there no bridge? Is the bridge broken? And what kind of prevention strategies can we create in order to prevent people from falling into the river in the first place? And so this is just a nice little basic model I like to think about when I'm explaining about the difference between public health and medicine. In terms of the areas of public health, there's 4 really main areas. And so the first one is the community and behavioral aspect of it. And so here, things that people do is like they help stop the spread of diseases. They help young people recognize and avoid dangers of unprotected sex, for example, or drug use, reducing obesity, all through education and development of healthy lifestyles through research and program implementation. The other side is, the other section is biostats and epidemiology. And here, essentially, this is the science that applies statistical theory and math for research in order to determine the trends and causes of diseases. And so here I really like to think about the epidemiologists and the biostatisticians as somewhat like the disease detectives, if you will. And here they really help determine what causes diseases or the injuries, what the risks are, who's at risk, and how to prevent further cases. In terms of the environmental health side, I think Elizabeth did an awesome job at describing what that looks like. And as you can see, it's pretty wide ranging, super complex, and it's a multifaceted profession spanning chemistry, toxicology, and engineers, for example. And then the last section is on policy and administration. And here, essentially, it combines health services administration, policy, business, and science, all for the goal of managing human and fiscal resources needed to deliver effective care. And a lot of the area that I've been working on for my research is around this policy and administration aspect in terms of how we can transform clinical research into policy changes. And so why is public health important to medicine? And so the reason why it's important is because of this concept called the social determinants of health. And this pretty much refers to social and environmental factors, essentially, that determine health outcomes. And a lot of these individual factors happen at different levels of the organization, leading from the individual all the way up to society. Some of these things include things like biological determinants. It includes behavioral and social cultural conditions. It includes the environments, the physical conditions in which we live in, economic conditions, gender, race, ethnicity, just as some examples. Another way to really think about the social determinants of health and how it functions in our society is using this socio-ecological model. And so as you can see, these are all the different levels of organization and society. And we can see that at the individual level, things like socioeconomic status or health status exist in that area. With interpersonal level, we have where social support exists. At the organizational level are things like your home or where you work. The community level is really like focused on the media, the social norms, the food environment around you. And at the largest level is public policy, specifically how legislation can impact health outcomes. And now the reason why public health is important to medicine is because of the health outcomes associated with the social determinants of health. And so when I think about health outcomes, from a clinical standpoint, I think about both the mortality and morbidity of certain diseases. And so now in terms of what health factors determine these outcomes, what I want you to pay attention to is the area of clinical care, in this area right here. And here we can see that this includes both access to care and quality to care. So when we think about the determinants of health, when we think about what determines your health status, we often think about, when you get sick, you go see your doctor, or you go to the hospital, or you go to the clinic on a regular basis, as that's what really determines your health. But it turns out that it's only about 20% that determines your health outcome. Now, the other things I want you to focus on as well is the other things that determine your health outcomes. This includes both the socioeconomic factors, health behaviors, and the physical environment. And what I want to highlight is that overall, 80% of what determines your health outcomes are the social determinants of health. and only 20% of what determines your health status is the access that you get to care. And so this is why studying the social determinants of health is really important for clinicians and for research scientists. And so this is just another way to think about the social determinants of health. When I think about health outcomes, I think about cancer, like diabetes, asthma, and depression. And also think about the health choices that determine these health outcomes, which are like diet, exercise, drinking, smoking, for example. But really what the social determinants of health highlights is really the context in which people make choices and these decisions. And the context includes these different social, economic, and environmental factors that we have discussed already. When it comes to what I see on a day-to-day basis in a clinical setting, this is important because the social determinants of health have direct clinical consequences. All that translate to shorter life expectancies. It translates to higher risk of certain diseases. It also means that people are more likely to die from certain diseases and also more likely to become disabled from certain diseases. And so in terms of the specific determinants I want to highlight here is social class, for example. Whether you're lower income, lower education, or lower occupational status, there's a lot of evidence that shows that people from these groups are higher risk of disease. The other one is race and ethnicity, for example. We know that minorities and underrepresented groups in this country are at higher risk of developing several different diseases. In terms, like for example, even with COVID, how we see that Hispanic individuals are more likely to die and more likely to be hospitalized from COVID, for example. And then gender as well, and then geography and neighborhood, and specifically here, people who live in like heavy industrialized areas are higher risk of asthma, getting hospitalized, higher risk of dying, and also higher risk of being in a food desert, which predispose them to more chronic conditions. And so to kind of bring this together, I'm going to talk about a clinical case. And so we have this emergency only dialysis for undocumented immigrants. And so imagine you're an emergency medicine physician at a safety net level 1 trauma center, and the patient that's coming in today has a chief complaint of shortness of breath. So you walk into the room, you introduce yourself, and you find out that you are taking care of Mr. Ramon Ruiz, who's a 35-year-old male, and he has a history of end-stage kidney disease. When you want to figure out more about what's going on, he discusses that he's been having some chest palpitations that started earlier today. He's also has this chest pain, some shortness of breath. And he says that he's had frequent episodes of these in the past, and they all get better with, quote unquote, the machine. When you talk about his other medical history, you find out he has a history of high blood pressure. He also has a history of type 2 diabetes, and he doesn't take any medications right now and doesn't have any allergies that he's aware of. When you talk more about his life, he mentions that he immigrated to the US about 10 years ago. He works in construction, doesn't have a primary care doctor due to insurance issues. And so then when you're thinking about taking care of him, you quickly dive into his chart, and you also learn that back in 2010, he presented to the ED originally and eventually was admitted to the hospital with an acute kidney injury. And then you later discover that 5 years later, his kidney injury progressed to kidney failure. And due to his immigration status, he wasn't eligible for any types of treatments, including dialysis or transplant. And then between 2015 and 2019, he's been presented to the ED almost at a weekly basis, requiring emergency dialysis to help treat his end-stage kidney disease. And when he talks about the machine, what he's really referring to is the dialysis that he's been getting. In terms of why end-stage kidney disease is such an important disease to discuss is because it has multisystemic effects on the body. So when we think about a neurological standpoint, it can cause headaches, lethargy, seizures, coma. From a hematologic standpoint, it can cause bleeding, immunosuppression, platelet dysfunction. From a cardiovascular standpoint, it causes edema or swelling. It can cause heart failure. It can cause pericardial effusions or like swelling around your heart. And it can also cause like lethal arrhythmias. And it can also impact many more organs in the system, including skeletal. It can impact your GI system, your dermatologic, your skin system, and also your respiratory system as well. And so my research question really was, what are the public health and individual consequences of emergency-only dialysis for undocumented patients? And really what I wanted to highlight here for my research is really starting off with the patient perspective, moving it to the health outcomes, and then taking a step further to discuss the policy implications. And so across the country, we know that there's around 6,500 undocumented immigrants who have kidney failure. And the other thing too is that there's a wide variation of the type of availability that's available for dialysis. And so you can have standard dialysis, which is happens about 3 times a week for about 5 to 6 hours. Or you can have emergency only dialysis, where you pretty much show up to the emergency room on the brink of death. And the only way that you're going to get dialyzed is if you're actively dying. We also know that undocumented immigrants are excluded from Medicare's end-stage kidney disease entitlement program. They're excluded from traditional Medicaid, and they're also excluded from provisions of the current Affordable Care Act. In terms of different types of dialysis that's available, there's the arterious venous fistula, there's the arterious venous graft, you can have a tunneled catheter, you can get peritoneal dialysis, but all that's for a separate lecture. Just know that there's very variety of different ways to get dialysis. But one thing I do want to highlight is that emergency only dialysis is super expensive for a healthcare system. In fact, it's actually 4-fold more expensive. It's around $285,000 a year compared to $77,000 for standard dialysis. The other things that we know too is that the overall quality of life is very poor for these people. Patients oftentimes report greater pain, and they also have lower level of overall function because they need to come to the ED on a weekly basis, pretty much on the brink of death. And here's this picture of a dialysis machine over here and a guy with a arterious venous fistula getting dialyzed for his condition. And so the first study I want to discuss is really the illness experience, what patients are experiencing on a day-to-day basis from having this disease. And so the objective of this study was to understand the illness experience from patients in a healthcare system who don't have cover or who do not have access to regular standard dialysis and rely only on emergency dialysis. And so this was a qualitative research project. We used semi-structured interviews of undocumented patients with end-stage kidney disease receiving emergency-only dialysis. And in terms of the outcomes, we pretty much described themes and sub-themes, and a total of 20 people were involved. And so the first theme that I want to quickly discuss is it's just very super distressing to be living on emergency-only dialysis, and pretty much because you're battling life and death situations. And so here's a quote that I want to read from a patient that really struck me. Sometimes I come in almost drowning. Last week, I was discharged on Friday, and by Tuesday, I came back and was doing badly. I couldn't breathe well. I had to go to the intensive care unit. The other theme too is that there's a lot of death anxiety associated with these weekly episodes of life-threatening illness. And so this quote that a patient discusses, I've had people pushing on me right here, my chest. I think it's happened 3 or 4 times, but I don't remember much except that my chest hurt a lot afterwards and my family thought I was dead. And so this research really identifies the human aspect of it, the personal perspectives of people who are experiencing this illness. The second step from this is really describing the health outcomes. And so this study was to determine the mortality differences between people who have emergency dialysis versus standard dialysis. And this was a retrospective cohort study of undocumented immigrants, again, with end-stage kidney disease, receiving these 2 different types of dialysis. And the 3 sites that were included includes Denver, Houston, and San Francisco. And essentially the main outcome that we were looking at is mortality. And then other outcomes we looked at was also healthcare usage. A lot of the data that we collected was demographic and clinical data from medical and administrative records. And so looking at this table, the main things I want you to focus on here are the 5-year outcomes for patients who have emergency-only dialysis. Here you can see that at 5 years, people have a 14-fold risk of dying from their disease if they're only getting emergency dialysis. And this effect becomes even more magnified when we look specifically among Hispanic patients. And for Hispanic patients, their hazard ratio or their risk of dying is 25-fold higher than people who are receiving standard dialysis. And so these people are at significantly increased risk of death from this. This is just another way to look at it, the data. And so A is all patients, and then B are Hispanic patients. The y-axis is pretty much cumulative mortality. And then in the x-axis is follow-up in years. And here you can see again that there are statistically and clinically significant differences between people receiving standard dialysis and emergency-only dialysis. And so after we did this and the data got out, many people began getting a hold of the data. And this included various people in the medical field, in the public health field, several stakeholders, and then the media. And now once the media got a hold of this, they started writing articles about this. They started even coming out on TV talking about this on certain news channels. And it quickly became evidence of how this practice in Colorado is predisposing people at increase in unnecessary death, and also has gigantic costs for our healthcare system. You know, it got so loud and it was being talked about so much that it got to the point that policymakers had to get involved, and they started to take this data into consideration. And so after that, after the policymakers got a hold of this, Colorado actually modified the emergency Medicaid definition, and they included end-stage renal disease now. So now essentially what happened was Colorado Medicaid made a regulatory change that now end-stage renal disease is a medical emergency, and thereby it expands and increases access of standard dialysis to undocumented immigrants. And so again, the media was able to get a hold of this, and essentially what they highlighted is it saved tons of money for our healthcare system, but most importantly, it's also saving thousands of lives a year. And so in terms of next steps for my research, and also a framework that I've been using for this, the nice part about it is that I've already started to work on my next steps. And so I started working on the study for pretty much describe the provision of care for outpatient dialysis for patients across the country. And so what we learned is that this wasn't just happening in Colorado, this is pretty much happening across the country. And there's a large variation, in terms of the care that people are receiving for dialysis. Before this study, it was unknown which states provide standard dialysis, given that it's more of a state's regulatory practice than a federal mandate. And so essentially what we did is we did a retrospective study again. We used geographic information systems and identified Medicaid language in state laws and policies in all 50 states. And essentially what we found was that outpatient dialysis is offered through 3 various mechanisms. One, state funding, like for example, how Colorado's doing it. The other way was national funding through charitable organizations and/or institutional support from hospitals. And the third mechanism, it's not being offered at all in some states. And so right now, 13 states offer outpatient dialysis through state funding. 14 states offer it through charitable funds, and then 23 states offer it only emergency dialysis. And so here's a map really of our country of kind of where this stands. And again, here are the green states, highlight all the different states where the state has created policies to provide standard dialysis. The orange states are the states that there is no state mandate, but there are charitable funds to help fund outpatient dialysis. And then the red states are the states that their patients pretty much rely on emergency only dialysis. And so in terms of next steps, where I hope to take this research is hopefully describe this and do further research across the country with the hopes of changing laws at the federal level, given that there's such large variation in the availability of standard dialysis amongst different states. A lot of this variation leaves many undocumented immigrants with end-stage kidney disease with essentially no chance of survival unless they get emergency only dialysis. And as we learned, this could be very expensive, and it also increases the risk of death significantly. And hopefully what I hope to do is really examine the evidence that's out there and begin to take purposeful action towards more sensible policy for immigrants with end-stage kidney disease. And so with that, I quickly want to recap the importance of having an approach to addressing health inequities using public health research. And so this medical research to public health policy is an advocacy framework essentially at its core. And it's a way that clinicians and public health practitioners can begin to incorporate into careers to transform a lot of the research that we're doing to actionable policy changes. This is something that I hope to continue as I progress through my medical career. And I just quickly want to describe the 4 basic steps. So the first one is, identifying the background information that exists, identifying a specific patient population or a specific patient outcome. And for my example, it was death from emergency only dialysis that we see on a clinical basis. And I encourage all clinicians and a lot of my colleagues to take this perspective, identify an issue that they see and do background research on it. The second part is conducting both qualitative and quantitative research to describe, explain, and solve the problem. And the reason why I highlight this is because oftentimes when we talk about research, we are very quick to jump to the numbers. This 14 times this, or 30% this and that. And a lot of times that tends to dehumanize a lot of the research that we're doing. And so that's why my medical research framework really incorporates qualitative research, because it's really important to humanize this research that we're doing, to bring those faces and those narratives to the forefront of the research that we're doing. After you conduct both your qualitative and your quantitative research is when you begin to engage your stakeholders, whether that's public health practitioners, other medical doctors, policymakers, and also the media really is a tool that we can use to bring awareness. And then finally, using all these steps to enact policy change. And so hopefully by now, you can see why the use of public health research in medicine is really important. And I want to close with this public health framework to highlight the importance of the emerging public health practice that I discussed in my presentation. And right now, traditional public health and medicine has been very focused on addressing the risky behaviors of treating disease and injury to prevent mortality. And I think, while I think this is a good approach, and I think we should maintain this approach, I also think that we should expand this approach really to begin to address the social determinants of health. Much of the research that's currently being done even now is now at the living conditions. And so seeing how we can change physical environments, the social environments, services, economic development to change health outcomes. But really what I encourage a lot of my colleagues and emerging researchers really is to take it even a step further, more upstream, where we begin to address the social inequities and the institutional inequities, which often tend to be at the core of a lot of the public health problems that we see today, whether we're talking about racism or immigration status, gender, sexual orientation. A lot of these are things that are within the purview of public health, and we can use policy as a tool really to drive upstream change to then influence downstream mortality. And lastly, I just want to quickly put in a plug for my book. It's titled From Margins to Medicine. And in my book, I discuss many of the things that I talked about in this presentation, but in much more detail. I highlight the background knowledge I have in public health and how it can be used to improve health. And I also include a lot of personal narratives as how this looks in my life. And so I think if you thought this presentation was interesting and you want to learn more, I think you will like my book, and you can find this on Amazon. And so with that, I'll leave with this quote from one of the most influential people in my opinion. And I want to give a special thanks to ARCS for, mainly funding a lot of the research activities that I've been part of, for connecting me with amazing mentors. I want to thank Denver Health for being the primary institution that I worked with for a lot of this research. I want to thank the University of Colorado as well for helping facilitate a lot of this research. And then super special thanks to Dr. Lilia Cervantes, who's been my primary research mentor and who pretty much took me under her wing. A lot of these efforts have been driven by her. And so I'm very thankful for her mentorship and for her taking me under her wing and making me the research scientist that I am today. And so with that, I'll end it right there. Thank you.
Oh, Will, another incredibly passionate, informative, and well done. You certainly emphasize that the social determinants of health often are the 70–80% of health. And Elizabeth, you told us it starts with clean water, and John Snow tracked it beautifully. I also wish we had more time to explore your personal journey. I wonder if each of you could give me 3 or 4 sentences about how you got started here. Who helped you? Tell me about it, Elizabeth.
Yeah, so I was started with that story of John Snow. I went to a museum exhibit at the Museum of Natural History and learned about that story and realized that public health was really part of what I wanted to study. And I studied it in a lot of different ways, but I think the way I kind of found my path to where I am today was through some excellent mentorship. So when I was in undergrad, I had the opportunity to do research in Nepal, and I had some really excellent mentors and scientists and researchers who, as an undergrad, kind of like Will was saying, having a good mentor is just a key part of it. And then I think kind of just continuing along my way with research, it's been key to find support both from my mentors, but also from my colleagues. So my friends in my program are some of the greatest support. And then also just from my family, who's on the call right now, they encouraged me from really early on to pursue my passions, to pursue what I was interested in, and to really, take this science approach. So I think having kind of all of these different mentors and all this different support throughout my life has been really key.
You've been a lucky, lucky girl. I can call you a girl, sorry. Will, in a few sentences, can you help us understand what was your initial motivation to move into medicine, and also this public health policy, as well as, we didn't even talk about your genetics research.
No, yeah, of course. So actually my interest in pursuing medicine actually began when I was a very young boy. My father, so I'm a first generation student, so nobody in my family is even graduated from high school. And I'm also a son of immigrants from Mexico. And so when I was a young boy, a lot of people would go to my father's little trailer asking for health advice. And so when I was a little boy, I thought my dad was a doctor, but in reality, he was a curandero, or like a traditional healer. And so when I was a sophomore in high school is the first time I even discovered what college was. And I figured out that I needed to go to college if I wanted to go to medical school. And so I remember going back home and asking my dad, I was like, hey, where did you go to medical school, or where did you go to college? And that's when he told me, he's like, actually, I didn't. And I didn't even graduate high school. A lot of the reason why we came here was to hopefully grant you those opportunities. And so that really originally inspired me to go into medicine. And then once I got to college and started studying about health outcomes and health inequities, I learned about public health. And I soon after that realized that I've been surrounded by public health my whole life, and really wanted to incorporate that into my medical practice as a future physician. And I just think it's such a valuable tool and such a valuable perspective. And I think it's really the future where a lot of medical science is really heading towards.
Well, there is no question that we need to build a stronger public health system. And I want to thank both of you for making that point so beautifully today. Your work, wow. I'm glad that you're here, and I'm glad you're going to continue, and you're going to change things for the better. I'm going to wrap it because I've been taught to try to start on time and end on time. So I'm going to tell you that our next session of ARCS Forward is going to be on machine learning and algorithms. And I think the date is February the 15th. So mark your calendars and look for the message to register. I also want you to know that each of you who's registered will receive a link of this recording session, so you can see those slides a little more slowly. And I hope that you will send comments on the survey and topics that are of interest to you to hear more about. Again, my deep thanks for attending. Willie, it just makes my heart very happy to know that you are curious about science and learn something about public health today. We hope to see you next time. Bye.
Thanks, everyone. Bye.